Good afternoon, Dr. Banker. Pleasure to have you with us.
Good afternoon.
Good afternoon, sir.
Good afternoon.
Sir, good afternoon.
Good afternoon.
Sir, we are live now. Good to go.
Good afternoon, everyone. Myself, Dr. Sonal Mehta, Lead Medical Advisor in TAS. I welcome you all to the teaching modules of infertility and USG. Intas is a pharma company headquartered in India and having business in more than 80 countries. Intas Women Health team headed by Mr. Satpathy and Mr. Janardhan in association with Iraq Fertility Society headed by Dr. Fadia have organized these teaching modules for postgraduates. Today, I welcome you all to the first module of this series of teaching sessions. Today, we have with us eminent faculties, Dr. Sunil Jindal sir and Dr. Manish Banker sir. First of all, I will briefly introduce to you Dr. Fadia. Professor Fadia Aziz is a currently working professor at Al Mustanzia Medical College, Department of OBGY, consultant OBGY at Al Yamak Teaching Hospital, Baghdad, Iraq. She is currently head of Iraq Fertility Society, IFS. She is currently a member of the Scientific Committee of Arab Board of OBGY in Iraq and member of Scientific Committee of Iraqi Fellowship in Reproductive Medicine. She is also a member of Administrative Committee of Iraq Society of OBGY. She has to her credit many publications, both locally as well as internationally. I welcome you, ma'am.
Thank you so much, Doctor. Yeah. On the behalf of Iraqi Fertility Society, me and our colleague members of society are glad to participate in this activity that we hope it will be beneficial of all of us. My great thanks to Intas Company to give us the opportunity to participate in this activity. And also I should express my great thanks to all lecturers involved in this activity as well. Thank you so much.
Right, ma'am. Today, the first session will be conducted by Dr. Sunil Jindal. He is a senior urologist. He will be speaking on management of hypogonadotrophic hypogonadism and male infertility management. He is by education, he is MS, MNMS, IAGE affiliations. He is chief consultant, laparoscopic surgeon, andrologist, and is scientific director at Dr. Madhu Jindal Memorial Hospital, Test Tube Baby Center, Meerut. He is vice chairman, Delhi ISAR, Delhi IAGE, over more than 250 awards from two different organizations, and he has many publications and presentations. He has written more than 8 chapters in 8 textbooks and over 200 national and international presentations. His special interest is infertility and fertility enhancing gynecological laparoscopic surgery, andrology, and medical and laboratory andrology. He is orator and singer by passion. I welcome you, sir. And today, our second faculty is Dr. Manish Banker, sir. He is the medical director, Nova IVF Fertility and Pulse Women Hospital. Will be having his introduction at a later stage. And I welcome you, sir. Now I hand over to Dr. Sunil Jindal.
Thank you very much. Thank you very much for your kind introduction, Dr. Sonal. It has really been a pleasure that a program like this is organized, and there is a time of about 1.5 hours which has been given. I'm Dr. Sunil Jindal. I am an andrologist. I do work for andrology, and it's very exciting because this is a line which has been ignored for a long time. And 50% we all know of contribution towards fertility or infertility, as people say, is by the man. And to understand the man and what all is done and how to look into it is very important. I have tried to organize my presentation into 4 parts. The first part is the past and the present. The second part is the medical management. In the third, I'll speak about azoospermia and surgical management. And in the fourth, we would look into the future and see what the future holds for us. So I'll begin now with the chair's kind permission to start with the presentation. So we all know that we would like to evaluate male fertility, and we all know that the evaluation of the male is of primary importance. So I'm going to bring about some practical tips and tricks, and I'm going to speak shortly about, though I've been given 1.5 hours, which is a good time, to speak in 4 modules. I would like you to ask as many questions as you want to, and I would try to have a conversation with you, which would be only by your typing and my speaking. So let's go ahead with it. Nothing is complete without knowing the past and the present concepts. So if we go back to Hippocrates, there was one thing which was clearly said by Hippocrates and Aristotle in the Greek mythology, that the child is born by a celestial blessing, but the blessing is only received once intercourse or copulation, as they used to say, has taken place. So it was always a celestial blessing at the time of Hippocrates and Aristotle. We all know about William Harvey. Who was William Harvey? William Harvey was a gentleman who gave us the details of blood circulation. And William Harvey in 1630 pronounced that the birth of a baby is by something which happens to the woman. And the role of man over here was only intercourse, but it was never understood of how it happens. But still, it, even according to him, was an unknown God-gifted phenomena, which means from the time of Aristotle till William Harvey, nobody knew anything of the role of the man, of how actually a baby is born. This was not until Antony van Leeuwenhoek. I'm sure you must be knowing about Antony van Leeuwenhoek. He was a Dutch, and he was a Dutch draper or a tailor. And Antony van Leeuwenhoek developed a microscope to see his cloth. While he developed it to see his cloth, he discovered algae, he discovered bacteria, he saw the plaque of his teeth. And one day, after having spent some time with his wife, he saw the remains in a microscope and for the first time saw sperms. When he saw this, he wanted to document it. So nowadays, in case I write a paper, I probably would send the paper saying that, well, sir, so-and-so, I'm writing a paper so-and-so. In case anything else needs to be known, please let it know from me. I would be very happy if any corrections are needed. He sent that paper to New England Journal, and in that he wrote that, sir, with your kind advice, what I herewith submit to you are the remains of my coital being. In case this disgusts this, you could throw this into the bin, but in case you feel it is worth publication, please go ahead with it. And it was published, and the rest is history, because the first sperm, as it was seen over here, and the diagrams which he made were fantastic, seeing the magnification at that time. And this was the microscope which was there. So the first sperm was seen not by a doctor, but by a draper. Then came the time which was the most amazing time. I'm sure you must have heard about John Hunter. John Hunter was the most celebrated English surgeon. And if you know about John Hunter could not study much because his parents did not have money. He came to work at the age of 14 with his brother in England, who was an anatomist. So his job was digging graves and dissecting bodies. And it is believed that by the age of 18, he had dissected and seen more bodies than anybody in the world. After this, he pursued a medical career and he became the most celebrated surgeon of the United Kingdom and probably the world for that matter. You must have heard about the Hunterian chancre of syphilis. And you must have also heard about the Hunter's canal, which in hernia is very important. So the first IUI in the world was done by John Hunter. When a man came to him with hypospadias, we all know what hypospadias is. Hypospadias is when you have the urethra which is not placed at the tip but along the shaft. When a patient with hypospadias came and said, I'm not having a baby, so he said, why don't you take the semen? He took the semen, placed it in a warm syringe and put it in the vagina, and pregnancy was there. So the first artificial insemination in the world was done by not a gynecologist, not an embryologist, by the great surgeon, John Hunter. Now we go on further, and this is very popular in the fertility circles, that in 1884, William Pancoast of Jefferson Medical College, Pennsylvania, performed the first documented artificial insemination in human beings. And what happened over here was that when he was sitting in his chamber, a patient came who did not have children. And by that time, he had a microscope. So he saw that he had no sperms. So he came back to his class with the difficult case. And he said, well, there's an infertile wife. And the husband, as per microscopy, doesn't have sperms. What needs to be done? So all the students were quiet, but one cheeky student said, why don't you take my semen and place it in? And you could have a baby. So the sperm and the semen of the most handsome boy of the class was taken, and it was placed. The patient was chloroformed, and this was done. When all the students saw what was being done, it was inseminated, and the wife underwent this treatment, and 9 months later, a baby boy was delivered. So this is a very interesting story of how the first IUI donor was done. But then something interesting happened. Following this, a lot of clinics started and opened up, which started giving children to people who did not have children by artificial insemination. In the British Medical Journal, there was a paper which was put in 1945 by Mary Barton. And Mary Barton showed the paper of the number of children who were born through artificial insemination. And when it went out, it appeared to be sacrilege. It appeared to be the worst thing to ever happen. If we know in England, the most important and the most powerful area is the church. And the church, the parliament debated on it. But they did not ban it and let it be done clandestinely. Do you know, it is believed that B.P. Weissner, her husband, fathered about 600 children. It's a very interesting past which is there in andrology. And if we go ahead further, then came the biggest breakthrough, which we all know about, the lovely Louis Brown. And the lovely Louis Brown was born as the first IVF baby. And the first IVF baby transformed the world of fertility. But still there was something which was a problem in low sperm count till in 1987, ICSI was performed. And in January 14, 1992, the first ICSI baby was born by the work of Palermo. And from that time, andrology has changed, because even if you get one sperm, you can have a baby. But something interesting is that women are unfairly paying the price for men's falling fertility. And the progress in andrology has slowed down because we all are doing ICSI to bypass the male fertility. And to understand it further, we need to understand that ICSI has been the biggest revolution for male fertility. And since the sperm count in the last decade has halved, and probably in the future would go down further, it is something to be really be bothered about. Now, present day, the first thing for us to understand in the present day is that the sperm count is going down over the century. We know that new diagnostics tests go far beyond the routine semen analysis. Antioxidant supplementation is a hot issue in male fertility. And today, a lot is available for azoospermics. In fact, up to 80% of azoospermic men can father their own children. And of course, spermatogonial stem cells represent a novel source of sperms, and in regenerative medicine, it's a new vista which will be opened, which I'll tell you about in the future. So what are the learning objectives at the moment? It would be that we know that WHO has updated the limits of semen analysis. We know new diagnostic tools are there, antioxidant, azoospermics, and we're going to speak all about this. So first of all, let us come to the semen analysis. The semen analysis, over a period of time from 1980 to 2010, we see that the WHO standards have changed. And the WHO standard actually is not a fixed standard. It is a fifth percentile of a population which has been able to attain pregnancy within 1 year of cohabitation, which means today it is considered that a sperm count of 15 million with a total motility of 40%, with a progressive motility of 32% is normal. By normal, I mean there is a fifth percentile of people who have had children. And apart from that, something important is that the morphology, which is now 4%, but this is by strict Kruger's criteria. So what earlier used to be considered as 40%, when you use Kruger's criteria in this, it normally would turn out to be 4%. Now, what are the important new diagnostic tests? One is sperm DNA integrity. The other is reactive oxygen species. And the third is Y chromosome microdeletion screening. So I'll give you a small background about sperm DNA integrity. How many of you know about and have ever got and understood and known about the sperm DNA integrity, the DFI index? If you do, please type in ID, I do, ID in the comment box. Yes, please. ID, I do. And so I'll just give you a small background. Key normal sperm chromatin is essential for paternal genetic transmission, and DNA fragmentation leads to unexplained infertility, recurrent pregnancy loss, poor outcomes in IUI and IVF. And the principle is that the quantification of sperm DNA breaks is there, and the specimen normally is a sperm or a spermatozoa. Now, how do you normally do it? Normally, in larger laboratories, what is used is the tunnel or the comet assay. However, it is seen that at times, what is normally done is the halo test, which is a simpler test to be done in laboratories. Now, why chromosome microdeletion? What is the background? The background is that in case there is severe oligospermia, then the principle is that the long arm of Y chromosome is tested in Y peripheral blood, and it gives a predictive value about the sperm retrieval. So in case it is in the AZF area, there are no retrievable sperms. In case it is in the B area, there are no retrievable sperms. But if it is in the C area, sperm retrieval is present in 70% of the cases. So this is a very good test which we normally would use. Now, this is the end of part 1. And in case there are any questions, I would like you to put into the chat box, which we could answer later on. Now, let's come to the part 2 of the medical management. So, let us understand our relatives. The chimpanzee, who's 100 pounds, has more than 1 billion sperms per ml. The man who's 180 pounds has 64 million sperms per ml. And a gorilla has about 5 million sperms per ml. So let's understand, the bigger the size, the smaller the testes, and the lower the sperms. So whenever you see a very big man, just understand it may not be necessary that he has the biggest testicles. And probably the smallest man may have the largest testicles. Well, it's just going ahead with it. But what we need to understand is that in the medical treatment, you have conventional as the genital infections, endocrine disorders, ejaculatory disorders, and the novel would be excessive oxidative stress and obesity-related male infertility. Now, in subclinical male genital infections, you could have subclinical infections. Endocrine disorders could be hypogonadotrophic hypogonadism. Now, in subclinical male genital tract infections, the most common bacteria are E. coli, Neisseria gonorrhea, Trachomatis, Uroliticum hominis. And the prevalence is normally 10 to 20%. And this normally would be seen in the epididymis, prostate, and seminal vesicles. It's a very important cause of idiopathic male infertility. So, most common are gram-negative bacilli. You could have gonorrhea, chlamydia, uroplasma, mycoplasma. But the antibiotics which normally are given in them are fluoroquinolones because they concentrate in this area, doxycycline, azithromycin, and cephalosporins. You need to, in case they are leukocytes, check whether they're round cells or they're leukocytes. So what you do is a peroxidase test, because whenever you see that there are too many pus cells in the semen analysis, it is not necessary that they may be pus cells. There is a very high possibility that these cells may be round cells. So it has to be diagnosed by the peroxidase testing. Then, in case there is subclinical infection, it could lead to motility impairment, subfidelity, and decreased DNA integrity and morphology impairment. Wherever leukocytes are high, the DNA fragmentation is high. You can give these patients antibiotics and anti-inflammatory with antioxidants. Hypogonadotrophic hypogonadism, when the FSH, LH is down, and in these, along with testosterone, in these patients, you give HCG and HMG. HCG is given 2,000 to 5,000 international units twice a week. And once the serum testosterone comes back to normal, at that time you add HMG in a dose of 150 twice or thrice a week. And you would continue this, and normally these sperms would appear in 3 to 12 months. This is a very interesting case I had. A very rich lady whom I had known came to me, and she said, I want to buy the most expensive sperm for my son. So I said, why can't I see your son? She said, he has no sperms. This was about 11, 12 years back. So when I saw the report, I knew it was hypogonadotrophic hypogonadism. So I told her, the best sperm or the most expensive sperm in the world will be your son's sperm. So we gave him HCG, and we got sperms, and we did an ICSI, and in the ICSI finally gave birth to two beautiful babies. After that, we have had a large series, and in this large series, we have realized that about 75% of these people can be given babies naturally by IUI or by ICSI. So it's important to diagnose them. It's important to give gonadotrophins, and few can conceive naturally. In Klinefelter syndrome, you again need to give HCG before sperm retrieval. And in non-obstructive azoospermia as well, you need to give HCG. In ejaculatory disorders, as retrograde ejaculation, you could use ephedrine sulfate, pseudoephedrine sulfate, and imipramine. And once you have done this, either they would ejaculate or you could use the urine to retrieve sperms from the urine. And at times, what ultimately is done is an ICSI. Oxidative stress, very important. And this oxidative stress is going on phenomenally. The answer to oxidative stress is it leads to DNA fragmentation. It is seen that in IUI, in case the oxidative stress or DNA fragmentation is elevated, the chances of pregnancy are only 1.5%. And in case compared to 19%, and in IVF, the chances are less with a high DNA fragmentation compared to ICSI. This is because what happens is that the oocyte repairs the DNA in ICSI. And because of this repair, the chances of pregnancy in ICSI are higher. What are the best antioxidants? Vitamin E, folic acid, vitamin C, libus increase. What we would normally give to these people, we would give them vitamin E, vitamin C, zinc, polonium, astaxanthin. You could give them folate, you could give them zinc, lycopene. All these drugs are important as antioxidants and very useful. Now, obesity related, whenever the fat is more, there is conversion of the testosterone into estrogen. And not only that, there is leptin which is secreted, and this leptin in turn leads to the situation of a negative feedback at the hypothalamus. So the sperm density decreases in obese people. And along with that, there is also erectile dysfunction, hormonal disorders, and it leads to infertility. So let us see this over here. We'll understand that what happens is that from the pituitary, you have FSH and LH. FSH and LH leads to testosterone. This aromatizes in a fat man to estradiol, which has a negative feedback to stop the secretion and decreases testosterone further. And in the adipose tissues, leptin is secreted, which goes to the hypothalamus and disturbs it. So empirical treatment is not to be given. Let us understand. A lot of people give androgens, empirically HCG. It is not to be given. There's specific areas where it needs to be given. Injectable testosterone is never to be given because it could lead to azoospermia. And now anti-estrogen are the most common used. Clomiphene and tamoxifen have been evaluated. Tamoxifen as 25 milligram is normally given where the testosterone level is low normal as a daily dose. And you could also have a lot of well-designed studies, and a few of them are in favor, a few of them are not in favor. However, clomiphene is a drug which can be given to men where the testosterone is down and the FSH is not too elevated. So the key message is empirical medication for idiopathic oligospermia is not recommended. Infertile males with hypogonadism are candidates for treatment. HCG is the treatment for hypogonadotrophic hypogonadism. Aromatase inhibitor is given in overweight men where the TE ratio is less than 10. HCG anti-estrogens help in boosting testosterone production, and a minimum of 8 to 12 weeks treatment needs to be given. Leukocytospermia may be caused by urethritis, treat with antibiotics. ROS production is increased with leukocyte numbers, and antibiotic therapy is suggested, but the effect on treatment is unclear. Oxidative stress is a main factor. Antioxidants may be needed. Hello? Yes, I had lost the connection. Am I there now? Am I there now?
Yes, sir.
I'm there? Okay.
Yes, sir. Yes, sir.
So I lost the connection, the net
Yeah.
connection. I've come back to the other connection. So I'll just share my slides. So I have talked about the medical management, and now I would go into the azoospermia part of it. Do we need a break? Dr. Sonal? Dr. Sonal?
Sir, it's okay. It's okay. We can continue, sir. It's okay.
We can continue, sir.
We can continue?
Yeah.
Okay, I'll just take a 5-minute break. I just like to have, I was just busy with the case operating. So I just
Right.
like to have a cup of tea. So I'll just take a 5-minute break. Huh?
Yes, sir.
I'll just, if there are any questions which are there, you could collect them. And because I'll just take a 5-minute break. I was not able to have lunch and I had just come back
Sure,
straight from
sir.
the theater. So
Yeah.
I'll just take a 5-minute break. So I finished half of it. I'll come back just in 5 minutes. Huh? I'll come back. So during this time, Sonalji or the support team could play some music. I think that would be great.
Yeah.
Or in case it is not there, Dr. Sonal, anything else could be discussed. The third thing which I'm going to discuss now would be azoospermia, which I would discuss soon. I'll just come back in 5 minutes. Huh?
Fine. Support team, can you display anything? So meanwhile, if you have any questions, you can put the questions in your chat box and we can discuss with Dr. Sunil Jindal. I hope I am audible.
Hello, check. Is my voice audible?
Yes,
Am
sir.
I audible? Yeah.
Yes, sir.
So I'll just start the third part, which is the azoospermia. And in azoospermia, we would like to go ahead and speak about in azoospermia, I would like to bring ahead some algorithms. And by these algorithms, I'd like to explain to you of how do we go about seeing what algorithm, what kind of an azoospermia it is, and then plan ahead with that to see how to treat these azoospermic men. So let us first understand that azoospermia is not synonymous of sterility, and the complete absence of sperms in an ejaculate is azoospermia. It could be 1% to 3% population, or 10 to 15% of male infertility. Now, there are two types of azoospermia. It could be obstructive or it could be non-obstructive. Obstructive is when there is normal sperm production, but there is a mechanical blockage. And non-obstructive is when sperm production is deficient or absent. So, this is a small algorithm in which, in case it is obstructive, it's going to be a normal size testes. Endocrine profile will be normal, and there would be a mechanical blockage. And there is normal spermatogenesis. While in non-obstructive, it can be of two types. There can be a spermatogenic failure, where the FSH, LH is high, the testosterone is normal or low, and the testes can be small or normal. And then, of course, there can be hypogonadotrophic hypogonadism, which I had spoken to you about, where the FSH, LH are low, and they are small testes with poor virilization. Now, in a patient who has azoospermic and fructose is positive, you can have three conditions: hypogonadotrophic hypogonadism, primary testicular failure, or obstructive azoospermia. And in azoospermia of fructose positive, when you examine and see the FSH, if the size is normal and the FSH is normal, it probably would be obstructive. If the size is moderate or normal with an FSH which is raised, it can be equivocal. And a raised FSH with a small testes is primary testicular failure. Now, in case there is azoospermia with low volume and absent fructose, you examine the vas. If the vas is palpable, then it is an ejaculatory duct obstruction, which you will evaluate further. But in case the vas is not palpable, it probably will be a cystic fibrosis. And in cystic fibrosis, you need a genetic counseling, and you need to get the cystic fibrosis panel done for the wife. And then following genetic studies, you can do an ICSI to give them a baby. However, in case the wife also has a carrier, then a donor insemination may be needed. Now, in case there is azoospermia, absent fructose, palpable vas, ejaculatory duct obstruction, you do a transrectal ultrasound. In transrectal ultrasound, is the ejaculatory ducts are obstructed, cystic seminal vesicle, please proceed for a TURED, and sperms may be available. And in case it is not so and there is a fibrous testes, then you need to understand that it is non-operable, and PISA-ICSI is the answer for it. I have spoken to you about this. Now, in case there is a normal volume semen, you do a history physical examination. By the size of the testes and the FSH, you feel that it is suggestive of non-obstructive azoospermia. In case there is a low FSH, low LH, low testosterone, hypogonadotrophic hypogonadism. In case it's a low FSH, low LH, and high testosterone, these people must be taking anabolic steroids. How many people in your country, in these gyms, take anabolic steroids? Have you seen them? In case you have seen them, just type in seen them. So you have these people coming into your clinics, largely built, and you take a history, you realize they are impotent. You realize that the sperm count is down. And this is because of the use of anabolic steroids. And in case there is high FSH, high LH, low testosterone, you would like to get a Y chromosome microdeletion done before you take these patients up for a micro TCHC. Now, in case there is a normal testes and the epididymis reconstruction is possible, do it. Otherwise, you would like to do a surgical sperm retrieval if reconstruction is not possible. So what are the techniques? You have a technique of PISA, where you take out sperms from the epididymis. It is used in obstructive cases only. MISA, where you take the sperms out from the epididymis microscopically in obstructive azoospermia only. You do TISA in a failed PISA, or where you know favorably you will be able to get it. You do a TISE in failed PISA or non-obstructive azoospermia, and you do a microsurgical testicular sperm extraction in non-obstructive azoospermic cases only. So first of all, let us see this. This is a PISA. So in a PISA, what is done is you get hold of the epididymis, you feel the epididymis, you take a BD syringe with a 24 gauge needle. This has media in it. You pull out the media. With the media, you pull out sperms from the fullest portion of the epididymis. You place them in a dish and you send it for observation. PISA, you use a 24 gauge needle. TISA, you use a 19 or a 16 gauge needle. And testicular biopsy, of course, you open up. So if you see over here in this video, you see this is the way normally an epididymis with inspissated sperms would look like. Now, in case this is a PISA, sorry, it's written wrong. It's a PISA. And for a PISA, normally, if you do not get sperms with a BD syringe, you would then use a 21 gauge butterfly needle and a 10 ml syringe to get sperms. And by this methodology, you unclamp and you take this material out, which you're going to take into the laboratory. Now, how do you do a TISA? Well, a TISA would normally be done by a 16, it's written wrong, by a 16 or an 18 gauge needle. And what you normally will take is a 20 ml syringe. And then you are going to, it's not a 10 ml, it's a 20 ml syringe. Then you're going to put it into the parenchyma, move it in the parenchyma, and you are going to pulverize a little bit of the seminiferous tubule and take out this material, which you are going to use to extract sperms. Now, sperm retrieval in obstructive azoospermia is in the tune of about 95%. And in fact, in obstructive azoospermia, since the lady is normally fine and is young, the chances of pregnancy are very good by ICSI. Now, it has been seen that if you use an ejaculated sperm versus a surgically retrieved sperm, in obstructive azoospermia, you would realize that the fertilization rate, the pregnancy rate, and everything is fine, but you also see that it is at par with an ejaculated sperm. If you compare it to fertile donors, even over here, the fertilization, the good quality embryos, the clinical pregnancy rates, and the live birth rates are similar. So what happens in non-obstructive azoospermia? In non-obstructive azoospermia, it is like a tree with apples. So the apples are the area where spermatogenesis is taking place. So from these areas, sperms can be picked up, and picking up these sperms is very important. And how will you pick up these areas from the testes is what the art is. So it could be a window technique biopsy where you take a small biopsy of the tissue. This normally would be done where you have not been able to, it is an obstructive azoospermia in which PISA has not been possible, or non-obstructive azoospermia with hypospermatogenesis, where you believe that in case you are not able to get sperms in this, you would extend it to do either multiple TSA or a micro TSA. So multiple incision is done normally in non-obstructive azoospermia if you're not doing a micro TSA. And what you would do in this is open up the testes and take multiple biopsies from different areas. And these multiple biopsies from different areas, you're going to check, and you will check if sperms are present in this or not. Now, how do you prepare testicular and epididymal spermatozoa? To prepare them, what you do is you normally mince the tissue and you strip the tissue to take out sperms from the tissue. Once you have done this, you would have sperms present, which have been stripped out of the seminiferous tubules. When you see this under a microscope, you would be in a position to find then sperms in this. This is a whole lecture in itself, how to prepare the dishes and how to prepare sperms. But now you could just bring out a few more things. You could do needle mapping of the testes. Now what happens in needle mapping? You mark out 16 areas in the testes. And you have a dish on which there are 16 drops. You do a TISA in these 16 areas, and after taking this out, you put them on the area or the drop. And in these 16 areas, wherever sperms are available will be the place where you would go in further to take out sperms from the seminiferous tubules. Now, how would you do a TISA mapping of the testes or a tephna? Over here, just see over here. Before going ahead for a micro TSA in a non-obstructive azoospermia, you could do this procedure. And in this procedure, when you put in the needle and you pull out, what you would normally get is some tissue, which with a micro forceps, when you take out, you're going to get a reasonable chunk of tissue from which sperms can be retrieved. So at times you don't have to put in a knife on the testes. We have given birth to Klinefelters. We've given birth to cancer survivors, maturation arrests, small testes, their own children. And all these procedures we have done to get basically the sperms of the father. And because, let me be honest with you, to give these people their own genetic child is priceless, not only for them, but even for us. Now, micro TSA is a beautiful technique which I'm going to speak to you about. It is done under general anesthesia. No betadine is used. A single mid-portion incision is given in the testes. Testes parenchyma is exposed. Magnification is used to search for enlarged seminiferous tubules. If enlarged tubules are not seen, any tubules different from the remaining are excised. And it is mainly used in Sertoli only where you have to do it because it's very difficult at times to see enlarged tubules. And if tubules are identical, we are going to take in random biopsies. So what you do is you open the testes, and you're going to take out some tubules which are larger first from the first plane, not from the deeper plane. So using this technique, we would be able to get sperms from about 60% of people of non-obstructive azoospermia. And we've been able to give birth to so many people who never thought they would be able to have their own children. This is how it appears under a microscope. So this is how sperms look in a testicular sample. Now this is an ICSI. It's a very old video, so the quality of the video is not good. I think it's a 14, 15-year-old video, which I had made it in a very an old system which I had of recording. So once you have identified the sperm in a testicular extraction, it takes time. In micro TC, at times we have to spend about 2 to 3 hours to find even 2 or 3 sperms. But then to give their babies, it's priceless. So now the hormonal therapy I had spoken to you about, clomiphene, estradiol, but this normally we also give before a sperm retrieval. In case the testosterone is down, we could also give these patients HCG. This I have spoken to you about. Now let's go on to the future. The future is very interesting. And the future is interesting because we have a lot of things lined up ahead in the future. So what we have is, presently we have sperm functioning tests, microsurgery, genetic diagnosis. But in the future, it's going to be an era of genomics, transgenomics, proteomics, and metabolomics. Now, please, we need to understand, let's understand this. I don't know if you can see my mouse over here, but you know, normally the standard procedure would be that you get a sperm and you store it and do an ICSI. But in the future, you could do a testicular biopsy, take the tissue out, do a transplant into an animal, into the same person, or into an organ culture. You could culture it to make sperms to use them. Or you could use these cells and you could use spermatogonial stem cells, culture them to sperms. Or in the future, it may happen that you could take a skin biopsy, use pluripotent stem cells, and make sperms out of that and inject them further. So now let's understand one small thing, that the primordial cells are these spermatogonial stem cells. So if spermatogonial stem cells are present, and even if primary spermatocytes are not present, or any type of spermatogenesis is not taking place, and if you could take these and do in vitro proliferation to get sperms, you probably would be able to solve a very big problem. So you can have male transplantation, germ cell transplantation, xenotransplantation into animals. Functional genomics would be very important, and in vitro generation of sperms from spermatogonial stem cells has been done in rats. Spermatogonial stem cells have been taken in rats. Sperms have been made in the lab. With those sperms, mice have been inseminated and children are born. So similarly, the only thing is in Japan, this was done in fact by 2011. But in men, it has not been possible till now because they have not been able to make an organ culture, but that would be there soon in the future. CRISPR is a very exciting technology where we know that what does a virus do? It replicates the genome and replaces it. So in CRISPR, what is done is, it similarly, genes can be replaced. And the replacement of genes would bring us to an area of that, supposing you have husband-wife thalassaemic. So from the area of the embryo, the thalassaemic gene could be taken out and could be replaced. Similarly, you could use it for diabetes. But the interesting thing in the future would be that you could make designer babies and you could have an Albert Einstein being made by the genome, or you could have Sachin Tendulkar. So the cricket team in the world would have so many Sachin Tendulkars if they were made, but I don't think ethically that would be possible. Another thing to ponder about, because this would be there in the future, a man and a woman give a sperm to have a baby. In case there are two men who want to have a baby, then a pluripotent stem cell of one man could be converted into an oocyte, and with a sperm, the baby could be kept in a surrogate. But in case there are two women who want a child, then one pluripotent stem cell could be turned into a sperm, and they could have their babies and one could keep the baby. But the interesting thing is, in women, they could never have a son. So with this, looking at the future perspective, I'm going to end my talk now. And thank you very much for this patient hearing. I've really loved being here with you. Any questions which are there? because I have a 4:45. I already have another presentation. So I could just
Right, sir.
answer 2 or 3 questions, then I'd like to leave.
Right, sir. Thank you, sir, for giving a very insightful and practical lecture. There are many questions and they are appreciating your talk, but I will be taking a few of them. So they are asking, is there any role of karyotype in the investigation protocol of oligospermia?
Karyotyping is done whenever you feel that the people have had recurrent pregnancy loss, because it could be a Robertsonian translocation, which could be found. In patients who have oligospermia and the sperm count is less than 5 million, you can do a karyotype in these people, and you would also like to do a Y chromosome microdeletion in these people.
Correct, sir. The second question is, in clinically diagnosed varicocele, even if semen parameters are normal with history of infertility, why don't we operate? Because surgery can reduce the sperm DNA fragmentation.
That's a very nice question. And normally, till now, the guidelines say that there needs to be infertility, there need to be semen parameters which are low, and there need to be a clinically palpable varicocele for you to operate. This is a very big gray area in which they consider that the semen DMA fragmentation would be high in varicocele, and the functional capacity of the sperms would be better in case we do a varicocele surgery. But even over here, the proof is not there, and it has not been evidence-based. So that is the reason probably it has not come into the guidelines.
Which one is best to measure, total testosterone or free testosterone?
Total testosterone is very easy to measure. Free testosterone is difficult to measure. So the way to do about it is that you, in the morning, empty stomach, you take the sample and you take a total testosterone. In case the total testosterone comes borderline, you go ahead in these patients and do a free testosterone.
Right, sir. Y chromosome microdeletion is expensive. Can I bypass this? Any other method of test?
In case the sperm count is less than 5, and in case the patient is azoospermic, it's very important to do a Y chromosome microdeletion, because in case you plan a micro TSA, for the patient to undergo a very expensive micro TSA and to find that by Y chromosome microdeletion he could never have got sperms would not be correct.
There is a practical question. One patient had 1 million sperm count, undescended testes. FSH was 22, testosterone was 110, 110. And what is the treatment of choice?
Freeze the sperms, because normally in bilateral undescended testes you don't get 1 million. Please freeze them. First thing. Second thing, give the patient HCG. Once the testosterone becomes normal, go ahead and check if the sperms improve. Freeze them further. Go ahead for an ICSI.
In hypogonadotrophic hypogonadism, for how long continue treatment with HCG and gonadotropin? And if we stop treatment, how long the effect of gonadotropin will be there if patient semen analysis getting improved? This when decline after stopping the treatment. Means
HCG and
yeah. Right, sir.
See, HCG is a replacement for LH. FSH replacement is HFG. You could use FSH as well. So since the body is not producing it, whatever you're giving from outside is going to produce. The sperm cycle is normally 3 months. But you do not give HMG till the time the testosterone is normal, which means that you would normally have to give these people about 1 to 2 months of HCG and then add HMG, which is going to take another 3 months. As long, if sperms appear, as long as you give them this injection, sperms would be there. When you stop, sperms will not be there.
Other question is, when DNA fragmentation percentage is high, what is next step?
You have to find why the DNA fragmentation is high. You have to see if the patient has leukocytospermia. If there is leukocytospermia, you need to treat it. If there's infection, you need to treat it. If he's a smoker, stop smoking. If he's exposed to pollution, stop that. If he has a varicocele and it's a clinically palpable varicocele and they are infertile and the sperm parameters are not normal, go ahead and operate. Give the patient antioxidants. Antioxidants need to be given for at least 3 months. This is what you need to do for DNA fragmentation.
Correct, sir. Ideal duration of antibiotic therapy for infection first cell in semen sample, and is there any preferred antibiotic?
3 to 6 weeks. I have already shown in the chart
Yeah.
that there are fluoroquinolones, doxycycline, azithromycin, Septran, which concentrates in these areas. So these are the antibiotics which need to be given. Dr. Sonal, Dr.
Right, sir.
Sonal, you'll have to excuse me because
Yeah,
I'm getting calls now from that place, and
yes,
it's
sir.
just
Yes,
7 minutes
sir.
left. 4 to 5, I need to run a panel over there.
Right. Thank you, sir. It was very great, great lecture, and I would like Dr. Fadia to say a few words.
Thank you so much, Doctor, for very nice presentations. Hope in the future we'll have another lectures in this field with more questions to be asked. Thank you so much.
Thank you very much, Dr. Fadia. Thank you,
you.
Dr. Sonal, and thank you for the lovely audience which you have been. I've really loved being
Thank you
here.
so much.
I wish I could see on Zoom all of you, and I could ask you questions and have an interactive session with you. I would have really loved it. Thank you very
Thank
much
you
for
so
being
much.
there. I've loved every moment being here. Thank you.
Thank you, sir.
Thank you so much.
Thank you, sir. Thanks a lot.
So now we can have break for 5 minutes.
Yeah,
10
we can
minutes?
have. Yeah, madam. We can have a break for 10 minutes, and before then we can start the new session.
Right. Hello, Sanjeev.
I cannot
Sanjeev?
start the video because there is a message that the host has stopped it. I get a message that your video cannot be started because the host has stopped it.
Sanjeev? Sir, I'll ask the support system.
Okay, now I'm able to start.
Right.
Okay. It is a conference છે મારી 6:30 સુધી લઈ લે હમણાં કાગળ મારાથી 6:45 સુધી મળશે નહીં.
Sanjeev, shall we start?
Ma'am, we can start now.
Right. So after a short break, now we will have our next faculty, Dr. Manish Banker, sir. He will be enlightening us on basic workup of male and female infertility, ovulation induction in anovulatory patient, PCOS. Dr. Manish Banker, I will be giving a very short, brief introduction of Dr. Manish Banker. He is Medical Director, Nova IVF Fertility and Pulse Women Hospital, past President, Indian Society of Assisted Reproduction, that is ISAR, recipient of the Professor B.C. Roy Award 2018, Chairman, Infertility Committee, FOXY 2007 to 2010, Regional Representative, International Committee for Monitoring ART, that is ICMART, and member Surveillance Editorial Board IFFS, founder board member Aspire, member Draft Committee of ART Bill of India ICMR, member of board Poseidon Group. This is a very short introduction of Dr. Manish Banker. With this brief introduction, I welcome you, sir. Dr. Fadia ma'am, would you like to welcome, sir?
Yes, thank you so much, Doctor. Thank you so much. We are happy to be there and to hear to your lecture. Thank you so much.
Thank you very much. It is indeed a pleasure to be invited to this very interesting session on educating the postgraduate students and the gynecologists on basic management and of infertility. So over the next 30-35 minutes, I will share with you my thoughts on how do you work up an infertile couple in the 21st century. I will take you through whatever investigations that are available in our armamentarium, and we'll discuss and debate as to what are relevant today and what investigations are not relevant. Following that, I will have a talk on how do we manage anovulation, and then we can take question answers after both the talks. So let me start with the first presentation. So infertility is defined as the inability of a couple to conceive after 1 year of sexual intercourse without using any contraception. It is after a lot of efforts that WHO has finally recognized infertility as a public health issue. But what we all know that infertility is generally used to denote that a couple has a reduced chance of conception compared to the general population. It does not mean that the couple will not be able to get pregnant. Now, as I mentioned earlier, we traditionally start evaluating a couple after 1 year, but there are exceptions to this rule. This is very true if the woman is older. Let's say she's above 35, more so if she's above the age of 38 years. Or very importantly, if the couple doubts their fertility potential, because you'll have some couples who have problems in intercourse, or the man has noted that he has bilaterally undescended testes, or a female who knows she has had surgery where the ovaries have been removed. So whenever the couple has some doubt, and even if they come soon after marriage, we should give them a basic workup. So presence of certain very glaring abnormal factors, or when the couple has any doubt, we should not wait for this traditional 1 year period. Now, how did this 1 year period come in? This is based on this very old publication as to what are the chances of a couple to become pregnant in 1 month. Now, if the couple has been trying very recently, that is, the duration is just 0, the approximate probability of that couple becoming pregnant in 1 month is around 20%. If they have been trying for 6 months, this drops to 14%, and up to a period of 1 year, it is still in double digits. The moment the couple has been planning a pregnancy for more than 1 year, it drops into single digit figures. And hence, the moment this drops below double digit, we would investigate and, if required, start treating that particular couple. So this 1 year limit is not an arbitrary limit. It is based on this scientific evidence. Certain very fundamental factors that we should always evaluate the couple as a unit. Infertility is a combined problem, it is a couple problem, and one should not forget the male partner because he would be responsible either solely or as a contributor in nearly 50% of the cases. It is better to have a questionnaire so that you don't miss out any points on the detailed history. You should carry out a thorough physical examination and, very importantly, counsel the couple about what is their fertile period, because even though for us doctors it is very easy and simple, for a lay person they have no clue as to which day of the 30-day menstrual cycle is their fertile period. And we should ask pointed questions about having any issues related to coitus, because they might be ashamed, they may not come out with this information. So we should ask pointed questions regarding coital issues, and we should brief them about what is the fertile period in any given month. With this basic fundamentals, let us see what are our primary aims. The primary aims are first to identify a potentially correctable condition. This is very simple, that if you are able to identify a condition which is correctable, that should be your first aim. Equally important is to find out certain irreversible conditions for which assisted reproduction will be the only answer. For example, azoospermia, bilateral tubal blocks not amenable to treatment. So certain conditions where conventional treatments are not going to help, and even if the couple is young, has not had any other treatment, for them assisted reproduction would be the first and the only line of treatment. And the third category of patients would be those who have irreversible conditions where we do not have any answer and where adoption or donor insemination would be the only option. So we should very rapidly categorize the couple into one of these three. One, do they have a correctable condition? Then we treat that. Do they have a condition where ART is the only option? We take them up for ART. Or do they have an irreversible condition where adoption or donor insemination is the only option? Then we should very rapidly counsel them for this particular option. We should also remember the fundamental question that what does a patient want? Why has the patient come to you? The patient has come to you for pregnancy. The patient is not coming for treatment. Very important to remember. The patient is sitting in front of you. Her only question is, doctor, when will I get pregnant? She wants this pregnancy in the shortest possible time. She wants this pregnancy in the most cost-effective way. And she also wants this pregnancy in the safest possible way. So we need to tailor a treatment for the patient, which gives her a pregnancy in the shortest time, is most cost effective, and is also the most safe. So there are two new concepts which have entered into the infertility paradigm, and that is the time to achieve a pregnancy, and second is the cost to achieve a pregnancy. These two were not very relevant 10, 15, 20 years back, and we could take our own time in doing treatment in a very stepwise or in a prolonged manner. We could give a prescription of clomiphene citrate and ask them to come after a period of 6 months. These things will not last today, because for a couple, both these factors, time to achieve a pregnancy and the cost or the amount of money that they need to spend to achieve a pregnancy are very important. So let us start with the basic. And the most important aspect is to take a detailed history, because history will guide you as to how would you proceed with investigations. And in many couples, you would proceed with a certain set of investigations first based on what you find in the history. So age of the patient, something which is very, very commonly not taken into account. And this is probably the most important factor which determines the prognosis, because the quality of the eggs that a woman produces is dependent solely on her age, no matter how long she has been married, whether there are additional factors contributing to her infertility or not. Age is the single most determinant of the quality of eggs, and in some instances, it is the age alone which decides how we should proceed with treatment. We look at the menstrual cycle, the length. We ask a detailed obstetric history, how many pregnancies, if she has had any miscarriages, term of miscarriages, at what gestational age, with after the appearance of the fetal pole, before the appearance of the fetal pole, after the appearance of the heartbeats, before the appearance of heartbeats. You ask pointed questions regarding coital frequency and coital problems. We look into her duration of past treatments, what all investigations have been carried out, when these investigations have been carried out, and where these investigations have been carried out. Are they appropriately done? Do we need to repeat these investigations or not? Obviously, we ask for previous surgeries, medications, allergies, occupational history for certain exposure to toxins, smoking, alcohol, smoking for both partners, female as well as male, because this does have an impact not only on infertility, but also on the risk of miscarriage. We also should spend a few minutes on family history. Is there a history of early menopause? Is there a history of any other issues, hormonal disorders, metabolic syndromes in the family? And we specifically ask for symptoms like pain of any type, galactoria, or hirsutism. So we take a very detailed history of both the partners. We should then carry out a detailed physical examination. And one point again, which is not uncommonly missed, is to measure the height, weight, and the BMI, because the BMI is important in not only deciding the treatment options, but also when you're treating the patient, it helps in deciding the dosages. We look for galactoria, we look for symptoms of androgen excess, we carry out a detailed per speculum examination, a per vaginal examination, and we do a general examination to look for signs of certain endocrine disorders like Turner syndrome or Klinefelter syndrome. We need to do that as well. Once this basic history taking and complete physical examination has been carried out, we then proceed with evaluations. Now, ESHRE has divided the infertility tests into three categories. Category 1 are those tests which have an established correlation to pregnancy, and these are an absolute must. Very three fundamental tests: semen analysis, documenting tubal patency, we should see which method to use, and some method to document ovulation. Sperms, tubes, egg production. Three fundamental requirements for achieving a pregnancy, and we need to do the test for these three conditions. Category 2 tests are tests which have not been consistently correlated with pregnancy and are more or less obsolete. Once upon a time, people used to do a zona-free hamster egg penetration assay to look at the fertilizing ability of the sperms, or a postcoital test, or looking at anti-sperm antibodies. Today, we know that the results of this test do not consistently correlate with pregnancy. And the third category, where we are very sure that these have no bearing with pregnancy, and these are an endometrial biopsy to date the endometrium, do a clinical, an ultrasound to assess a varicocele, or to do testing for chlamydia. And these tests, according to ESHRE, these have not been recommended. So let us start with the category 1 test. And the most important, most simple, but very often a test which is not properly done, and that is a semen analysis. Now, this is the fundamental test for a man, and in most instances, the only test. It measures the amount of semen that a man produces, and it also determines the number and the quality of sperms in the semen sample. This is the first step that we do, the first investigation that we carry out in a couple. The problem in semen will be found in nearly 30 to 50% of couples suffering from infertility. And we need to do the test under very standard conditions with an abstinence of 2 to 4 days. But it can be done with any period of abstinence. And ideally, I would like to do it on the day when the husband is there in the clinic, even at the time of the first visit, because if it is normal, it solves a lot of your problems. This is the test which tells you or gives you information about many things: production of sperms, patency of the male ejaculatory ducts, the function of the male accessory gland, and the ejaculatory function of the male. So this simple test gives us information about a lot of things happening in the male. It is ideally done through masturbation in a simple wide-mouthed cup. Make sure that the couple has not used any lubricant, because most of the lubricants have spermicidal properties. Sometimes husbands have problems with masturbation, and they can then be advised about coitus interruptus, where the man withdraws the penis from the partner just before ejaculation and ejaculates into a clean sample cup. Sometimes this is also a problem, and in those cases, we can use a special condom which does not have spermicides, and the semen can be collected in this condom during intercourse, and the collection from the condom can then be examined. But this is not with any ordinary condom. It has to be a special silicone-based condom without any spermicides. How many tests would you carry out? Again, a single normal test does not mean that there is no problem, because semen counts keep on fluctuating even in normal fertile males. So even if one count is normal, ideally we should have 2 semen analyses. And if one is abnormal, you should ideally have 3 tests. It is also important that these tests are analyzed at a monthly interval, because even a short illness, a short span of fever of 2 to 3 days can lead to severe suppression in semen parameters, and this takes time to recover. So if one test is abnormal, don't repeat the second test after another 2 to 3 days. Give them a month, repeat the second after a month. So 2 tests if they are normal, and 3 tests if there is an abnormality. Now, what is a normal semen count? And WHO keeps on revising the guidelines on sperm parameters, and the level of normal has kept on decreasing over the last few decades. A normal semen count should have a volume of 1.5 ml. It should have a total of 15 million sperms per ml. When we were students, it was at 60 million per ml. It then came down to 20, and now it is at 15 million. Out of this, 40% should have progressive motility or should have motile, progressive as well as non-progressive, but 32% of this should have progressive motility. 58% of the sperm should be live, and at least 4% of the sperms should have normal morphology if it is done by the strict WHO criteria. So 15 million per ml, 32% progressively motile, 4% morphologically normal. Based on this, We then have certain terminologies by which you could define the condition. If the problem is predominantly with the sperm count below 15 million, it is called oligospermia. If the predominant problem is motility, it is asthenospermia. If the predominant problem is morphology, it is teratospermia. And you could then have combinations of this. You could have oligoasthenospermia, oligoteratospermia, or you could have all the three things together, oligoasthenoteratospermia. Azoospermia is complete absence of sperms in semen. Hypospermia is when the semen volume is low. Hyperspermia when the volume is more. And aspermia is when the husband is unable to produce semen. Pyospermia is presence of pus cells. Hematospermia is presence of red blood cells. And necrozoospermia is condition where all the sperms in the semen are not only immotile, but they are completely dead. So based on the volume, count, motility, and morphology, you then classify the condition, or if everything is normal, then it is normozoospermia. Now, the semen count that you find helps you in predicting how urgently and how rapidly you should treat the couple. And this is a very important publication, again, nearly 40 years old, where the chances of a normal conception based on the motile sperm count has been predicted. So if you have a couple who has a motile sperm count of less than 1 million, and if that couple does not undergo any treatment, that couple has a 4% chance of a pregnancy after 4 years and a 9% chance after 12 years. And if the count is below 5 million, still the chances of a natural conception after 5 years is only 12% and roughly around 25% after 12 years. So whenever the count is below 5 million or sometimes even below 10 million, it immediately tells you about the urgency. And it is here that the age of the wife plays a very crucial role, because if she is 35, she does not have this luxury of 5 or 12-year period. So the severity of the sperm count should always be correlated with the age of the wife, because this will tell you how critical the problem is and how urgently should you start treating them. For the male, apart from the normal history, there are very specific points that one should ask. If the counts are low, ask them for their prior fertility. Has he fathered children earlier? Any childhood diseases like orchitis, they would give history of mumps orchitis, and you would immediately know what is the reason for their azoospermia. Or they have undescended testes, genital trauma or surgery. Common surgeries are torsion. If they have had history of infections, have they taken any gonadotoxic radio or chemotherapy? Is he in an occupation where is exposed to high degree of heat? Or is there a family history of any birth defects or mental retardation? Specific pointed questions directed towards the male partner. You then proceed with a detailed physical examination of the male. You examine the testis and you look at the testicular volume and the consistency. You look for the secondary sexual characters. You should palpate the vas deferens, especially if there is azoospermia. You look at the epididymis, are they turgid and food, which would point towards an obstructive factor. And you look for the presence of a clinically palpable varicocele. And if suspected, you may then proceed with a digital rectal examination. I'm sure some aspects of this azoospermic evaluation would have been taken earlier, but I'll very rapidly take you through how would you evaluate a man with azoospermia. And something which is not commonly done is to collect that sample and centrifuge it and look at the pellet, because sometimes you might miss an occasional sperm which would be present in the pellet, because even if a few sperms are present in the pellet, it by and large rules out obstruction. But if there are no sperms present in the palate, then you need to palpate the vas deferens and see. If the vas deferens is not palpable and there is azoospermia, it points towards congenital bilateral absence of vas deferens, and you look at epididymal aspiration, and at the same time you also evaluate for cystic fibrosis mutations. However, if the vas deferens is palpable, then it points towards a non-obstructive azoospermia, and there you then proceed based on the FSH levels, because this will guide us as to a possible cause. But no matter what the FSH levels are, you should always do a testicular biopsy, because no matter how small the testis is or how high the FSH is, it is ultimately the presence or absence of sperm in a testicular biopsy or the histopathological picture of the testicular biopsy which is going to decide whether this couple can conceive with ICSI using testicular sperms or not. Once the husband has been evaluated, you then proceed with evaluating of the wife. And the second category of tests which has a direct relevance on the pregnancy outcome are the tests for tubal patency. We should also remember that fallopian tubes are not simply a pipe which helps in movement of the sperms and the eggs, but it is a dynamic organ. It undergoes peristaltic activity. It has got ciliary function inside which helps moving the sperms and the eggs. So while testing for these dynamic functions, it is not possible. All we can test for is a mechanical patency. And this again should make you aware that a patent tube does not necessarily mean a functioning tube. However, if you find an obstruction, it gives you some idea as to the cause. You should also try to look at tortuosities, the length of the tubo-ovarian relationships. Now, there are multiple tests available today, but the three tests which are of relevance are a laparohysteroscopy, which is the gold standard, a hysterosalpingography, the age-old test, and a sonosalpingography, either saline or using a contrast. These three are the gold or the most commonly used test for testing of tubal patency. Now, amongst all the three, the advantages of a laparohystro is that you can assess the entire pelvis, the cavity of the uterus, and the pelvis. You can assess tubo-ovarian relationships. You can also diagnose and assess other pathologies like endometriosis, pelvic inflammatory disease, and it is both diagnostic as well as therapeutic. However, it is an invasive procedure with a risk of anesthesia and a marginal risk of any surgical complications. When you do a hysterolaparoscopy, you look for multiple things. On hysteroscopy, you visualize the cavity of the uterus and see whether there are any pathologies protruding inside. You look at the tubal ostium and you see the movement of fluid through this tubal ostium. And on the laparoscopy, you inject methylene blue, and apart from evaluating the entire pelvis, you look for spillage of methylene blue into the pouch of Douglas, which will tell you whether the tubes are patent or not. At the same time, if you find certain problems, you can correct them at the same stage. Common ones are looking at a submucous fibroid, you can do a resection, or there is a band of adhesion, you can cut this band of adhesion. Sometimes the tubes are blocked, there is a mucus plug, you can cannulate the tubal ostium and inject the dye. Or when you're doing a laparoscopy, you can see adhesions covering the uterus. Or you can find an endometrioma, this can be opened and drained, or you can carry out complete pelvic adhesiolysis. So a laparohysteroscopy is both diagnostic and therapeutic. And in a patient where your clinical examination or your ultrasound findings point towards a pelvic pathology, this is preferred over the other two tests. When your clinical examination is completely normal and the wife is young, you may then do the other two tests. And the commonest amongst that is a hysterosalpingography, where you inject the contrast media transcervically into the uterus and the tubes and look for the cavity of the uterus and the spill. It is cheaper, it is relatively less invasive, but it has certain problems. First, it is only a static image. It does not give a dynamic image unless when you're doing the procedure and you're recording or seeing on a CCTV. Second, it cannot see pathologies outside of the uterus. It does not give you any option of correcting this pathology and has a relatively high false negative and false positive, but it is cheap and it is relatively non-invasive. So studies have shown that it has an 81% sensitivity compared to a hysteroscopy for looking at intracavitary pathology, and the predictive value, a positive predictive value is 63%, whereas the negative predictive value is 83%. This is as far as intracavitary pathologies. When we look at the tubal pathology and patency, it has a false negative rate of 90% and a false positive rate of 21%. So this does have its own issues, but we should use HSG and laparoscopy as complementary to each other when we do workup of an infertile couple. We now have another test which is sonosalpingography, where instead of looking under the X-ray, you do it under ultrasound guidance and you inject either saline, which will appear as an echogenic fluid, or there are special ultrasound echogenic substances like Ecovist, which are very viscous substances, and you could inject those as well. So the advantage is that there is no radiation in it. It is an outpatient procedure. It is very cheap, but sometimes painful. Again, there is a false negativity and false positivity similar to that of the HSG, and you cannot assess the tubo-ovarian relationship, but it is a very simple bedside screening test. Now, generally, all these tests are carried out in the early proliferative phase of the cycle because one, the visualization is better because the endometrium has not proliferated. And secondly, if there is an inadvertent pregnancy, you will not disturb the pregnancy. These tests are not done if there is evidence of acute, either sexually transmitted disease or any kind of pelvic inflammatory disease, or there is abnormal uterine bleeding, unless you are doing it specifically to diagnose the cause of the bleeding. But for an infertility evaluation, it is not done in the presence of active bleeding. Again, it is not generally recommended if the woman is old or has a low ovarian reserve or the sperm parameters are extremely poor, because there you would resort to other methodologies for treating the patient rather than looking at the tubal factor, because the tubal factor is less likely to be the contributory cause of their infertility. We then move on to the third area, and that is look for the ovarian function and ovulation. You begin by checking the ovarian reserve as to how good the ovarian function is, and then we see whether ovulation is occurring regularly or not. And there are multiple tests available. It is here that the age of the woman is the most important parameter, because with increasing age, there is a decrease in ovarian reserve. And at the age of 35 and above, the ovarian reserve starts to decrease very rapidly. Now, how would you look for ovarian reserve? There are certain biochemical tests and there is ultrasound. Today, the most commonly used biochemical test for ovarian reserve is the anti-Mullerian hormone. It is a glycoprotein produced by the preantral and the early antral follicles. It acts by inhibiting the development of the Mullerian duct in a male embryo. During the process of folliculogenesis, it inhibits follicular recruitment. And by inhibiting recruitment, it contributes towards a monofollicular ovulation. So better the ovarian reserve, the more amount of inhibition that is required, and hence higher the AMH. Lower the ovarian reserve, lesser is this inhibition required, lower the AMH levels. It is essentially acting on follicles which are FSH independent, so primary and pre-enteral follicles. And because of this, it is not affected by your ovulation induction drugs. It is FSH independent. However, there are certain factors which can affect the AMH value, and that is obesity, ethnicity, vitamin D status, and also certain issues related to polymorphism and genetic variants. Smoking has also been associated with a lower AMH level. Normal levels of AMH are between 1 to 1 to 4 nanograms per ml. If it is measured in picomoles, then 1 nanogram is 7 picomoles, and anything above zero point 0.7 or preferably above 1, then it is normal. Below 0.7, it suggests diminished ovarian reserve. It is also important to remember that some evidence is coming in that in women with endometriomas who have not undergone prior surgery, and endometrioma also causes an increase in the AMH levels, possibly due to some in local inflammatory factors. And this is very relevant in a woman with endometrioma because if you rely on an AMH, it will be falsely elevated and it gives you a false sense of security. So if the AMH is elevated in the presence of normal ovarian risk, in the presence of an endometrioma, interpret this with a pinch of salt. The second hormone, which was very commonly measured in the earlier days, was FSH, which is secreted by the anterior pituitary in response to GnRH. We will discuss these hormones in detail during my third session when we look at complete hormonal evaluation. But FSH is the hormone which helps in recruiting follicles. And the better the ovarian reserve, lower is the need of FSH, and lower will be the FSH. Poorer the ovarian reserve, higher is the FSH required, and higher will be the FSH. The normal range is between 3 to 20, or in some bioassays between 3 to 12. It is ideally measured on the second or the third day of the menstrual cycle only, and it is always measured in conjunction with the serum estradiol level. It should never be measured alone. As I had mentioned, if the normal limit is up to 20, the ideal level is below 9. The moment this moves into double digit or it crosses 50% of the upper limit of that assay, it is suggestive that the ovarian reserve has already started to fall. We know that FSH levels fluctuate during the cycle. There is a dynamic feedback between the FSH and estradiol, and hence we should measure both the hormones together. Estrogen is produced by the granulosa cells of the growing follicle in response to FSH. Once the estradiol starts to get released, it gives a negative feedback and it lowers the FSH levels. So we should measure both the levels together. If you have an FSH which is normal and an estrogen, it is normal, everything is fine. But if the FSH is normal, but the estradiol is high, it again suggests poor ovarian reserve. If the estradiol is normal and the FSH is high, it suggests markedly reduced ovarian reserve. FSH and E2 also play a very important role in classifying what type of anovulation this is. And as we will see during my next talk, this helps us in deciding the treatment. So when the FSH is low, the estrogen is also low, it suggests a hypothalamic cause. When the FSH is normal, the estrogen is normal, it is normogonadotrophic hypogonadism. This goes in favor of polycystic ovarian syndrome. And when the FSH is high, the estrogen is low, it is hypergonadotrophic or suggestive of premature ovarian failure. So measuring both in conjunction will help you in deciding the possible cause of anovulation. We then move on to a test which is the most commonly used test, and that is measuring the antral follicle count. This is done with the help of transvaginal ultrasound. Antral follicles are small follicles, less than 10 millimeters in size in the ovaries. These are indicative of the follicles or primordial follicles present in the ovary, which are likely to respond, and a decrease in supply of primordial follicles will lead to decrease in the antral follicles. The normal antral follicle count again is in double digits. If it is 10 or less, it suggests that the ovarian reserve has started to fall. So it means when you do an ultrasound scan, and if you see that both the ovaries have 4, 5 follicles, you should not be happy. This is early sign of diminishing ovarian reserve. And when it falls below 4, it suggests extremely low ovarian reserve. You could also measure the ovarian volume, where we look at the length, width, and the depth. You measure the 3 dimensions and you multiply by 0.5. And if the volume is very low, again it is suggestive of low ovarian reserve, but it is difficult to calculate, not very accurate, and hence not commonly measured. So the 2 commonly used tests to measure ovarian reserve, one is your bedside ultrasound, and second is the anti-Mullerian hormone. We then move on to documenting ovulation. Again, there are multiple tests available for this, and let us see what are relevant today. Menstrual history gives us the first indication. If the woman has very regular menstrual cycle, has premenstrual pain, has mid-menstrual pain, it is unlikely that she has got anovulation. This points towards regular ovulation. If her cycles are irregular or she does not have menstrual cycle, it points towards anovulation. The basal body temperature measurement was very popular once upon a time. It was based on the thermogenic property of progesterone, that with ovulation and secretion of progesterone, there was an elevation of body temperature. And it was measured first day in the morning, measured with a spatial fertility thermometer where it was more accurate. But if you look at the pre-ovulatory period, it fluctuates between 97 to 98 degrees. It falls to its lowest level a day before ovulation and is then elevated by 0.5 to 1 degree Fahrenheit over the next 2 to 3 days. The advantages, it is low cost and very easy, but it has major drawbacks. One, it reminds a woman of her infertility first thing in the morning every single day. Secondly, it may not be clearly biphasic in a lot of patients, so it is not very routinely used. The second measure that you can do is measure the serum progesterone. Now, this is exclusively produced by the corpus luteum, which is formed post-ovulatory, a very small amount being contributed by the adrenal glands. In the follicular phase, it is below 1.5 nanogram per ml. Post-ovulatory, it begins to rise and it reaches 20 nanogram. So when you want to use serum progesterone to measure ovulation, you measure it 7 days after the presumed day of ovulation, and any level above 5 nanogram per ml provides reliable evidence of ovulation. So you do it either 1 week after the presumed day of ovulation, or you would measure it 1 week before the expected menses, because the luteal phase is always constant at 14 days, no matter what the cycle length is. A single value of about 10 is confirmatory. If it is lower than this, maybe you can repeat it once more. Then come to the urinary kits. These are very popular in certain countries because this not only helps in detecting ovulation, but it sometimes helps the couple in predicting ovulation in the next 24 hours. This involves measuring the LH levels in the urine at specific intervals. To have it done very reliably, you begin it about 2 to 3 days before the predicted day of ovulation, and you could measure it once or twice in a day. Once you start or once you detect the presence of LH, ovulation will generally occur over the next 14 to 26 hours, and this helps the couple to decide their fertile period. However, one of the most common method used to monitor and predict ovulation is transvaginal ultrasound, because this gives you an ability to directly observe the changes that happen in the uterus and the ovaries. In addition, it helps us in deciding and measuring or looking at any other pathologies. And let us see how this happens. The pre-ovulatory follicle typically grows at 2 millimeters a day. The endometrium grows by 1 millimeter a day, and the follicle disappears at ovulation. So this is how a normal ovary looks. It is ellipsoid in shape, slightly hyperechoic with a few small echogenic areas. These are the antral follicles. You sometimes might have to differentiate it from an echogenic bowel, but by and large, ovary is not difficult to miss. Immediately in the post-menstrual phase, the endometrium is very thin, linear. As the endometrium starts to grow or the follicle starts to grow, you start looking at the central follicles. These are small fluid-filled follicles, and you can see that this ovary has 1, 2, and 3 follicles, whereas this ovary has multiple follicles, 1, 2, 3, 4, 5, 6. So you measure the antral follicles. As the follicle starts to grow and starts to secrete estrogen, the endometrium starts to proliferate. And you then have an echo-free area with a central echogenic line, and it moves into this triple line feather. And this becomes few millimeters in thickness from a very thin linear line. Simultaneously, the antral follicles, which were less than 10 millimeters, start to grow, and you have one or sometimes two dominant follicles. The follicle is said to be dominant when it grows beyond 14 millimeters in size. It typically grows by 2 to 3 millimeters a day till it reaches a maximum size of between 20 to 24 millimeters before it ovulates. Around this time, the endometrium starts having its typical triple line appearance: the central endometrial cavity, this, the epithelium with the rich fluid, the secretions, and the basal layers. This measures at least 7 millimeters or above. And then you reach the ripe preovulatory follicle, which would be more than 17, 18 millimeters in size. Sometimes it shows a small cumulus oophracus at projecting at one of the margins, but this is not a must. You need not waste time to identify this. And the endometrium, again, completely triple line, fairly thick, 9 millimeters in size. And then you see the appearance of ovulation. There are multiple signs for ovulation. One, the follicle disappears and it gets filled with blood clot, or it completely disappears, or it has these crenated margins, or you see presence of fluid in the pouch of Douglas. So there could be multiple signs of ovulation: disappearance of the follicle, filling up of the follicle with blood, irregular crenated follicle, or presence of fluid in the pouch of Douglas. And if you still monitor it a couple of days after ovulation, you can see that now the endometrium has lost its triple line appearance. The central line has become indistinct. There is enhancement posteriorly, and this is the secretory transformation of the endometrium. Then we move on to the endometrial biopsy. Again, very commonly done in the early days. It was used to date the endometrium, and based on the noise criteria, one could see as to what day of the endometrial menstrual cycle is the endometrium. And for identifying a luteal phase defect, one needed to have a lag of more than 2 days. However, it has a lot of problems because there is a lot of inter-observer variations. When two people examined the same biopsy, there was agreement in only 24%. There are also issues with the predictive value because even with an out of phase biopsies, pregnancies went to term. So this is not a very accurate measure. So to summarize the category first test, semen analysis a must, examined by trained andrologist. You have three options: laparohistro, the gold standard for tubal evaluation, saline sonography and HSG also are good, and we should use this test in a complementary fashion. And for documenting ovulation, the mid-luteal progesterone or serial transvaginal sonography are the most popular ones. And to assess the ovarian reserve, it is the antral follicle count and the anti-Mullerian hormone. The category 2 test, the zona-free hamster egg penetration test, completely not done. Anti-sperm antibody testing also not done. Postcoital test, maybe it only gives us some indication if it is positive that the couple is having normal coitus. And what is done is about 2 to 12 hours after intercourse, in the pre-ovulatory period, a drop of cervical mucus is taken and examined under a slide, and we look for the presence of motile sperms. You look at the cervical mucus and the sperms, and a positive PCT tells you that normal intercourse has happened, but a negative PCT does not help you anywhere. So these tests are very rarely used. So this leaves us to a few other hormonal tests which are a routine part of evaluation. And the three hormones are TSH, prolactin, and the androgens. Now, TSH is produced by the cells of the anterior pituitary acting on the thyroid. The normal values for TSH are between zero point 0.4 and 5, but during pregnancy, it is ideal that we bring it to below 2.5. So despite 95% of the population having a TSH of below 2.5, there is little evidence today to treat women who have TSH between 2.5 to 5, the so-called occult hypothyroidism, because there is a possibility of over-treating these women leading to bone loss. So whether to use this cutoff of 2.5 or the older cutoff of 4 or 5, it is still controversial. What about anti-TPO antibodies? Again, there is some evidence that this does lead to repeated miscarriages, not infertility. And in patients with repeated miscarriages, it is worthwhile measuring this. Now, when would you evaluate TSH? Ideally, it should be a standard pre-pregnancy test, but it is all the more indicated when there is some evidence of hypothyroidism like weight gain, loss of appetite, fatigability, dry skin, or drowsiness. And you should evaluate this because if there is untreated hypothyroidism, it will lead to ovulatory disorders, and it would also have adverse pregnancy outcomes like miscarriages, preterm deliveries, or anemia. The second hormone, and probably the most controversial amongst all female hormones, is prolactin. Now, this has been shown that if it is significantly elevated, it leads to anovulation and amenorrhea because it interferes with the GnRH pulse rhythm. But whether marginal prolactin elevations lead to infertility or not, that is something which is still controversial. So if it is mild, it may only cause a short luteal phase, leading to maybe marginal ovulatory disturbances. But if it is above 50, it will definitely cause oligomenorrhea or amenorrhea. And if it is above 100, it is also suggestive of a pituitary tumor, and you should carry out a pituitary CT or MRI. It is also important as to how and when you measure the progesterone, because it is usually measured mid-morning, neither after complete fasting or after a full meal. And if there is a single elevated reading, it should always be confirmed, or you take a pooled sample 30 minutes apart. Breast simulation will also read to falsely elevated. So if you have examined the patient to rule out galactoria, don't measure the prolactin levels immediately. A lot of drugs, very commonly used drugs like antacids, also interfere and cause hyperprolactinemia. So you should ask for the history of drug ingestion. The normal range is between 2 to 20 nanograms, and it should always be measured in women who have anovulation, irregular cycles, or other features of hyperprolactinemia. The prevalence of hyperprolactinemia is around 17%, and importantly, it is a very simple condition to treat. This then takes us to the last category of the hormones, and these are the androgens. Amongst those, DHEA and DHEAS are of adrenal origin, androstenedione is of ovarian origin, and testosterone is from the adrenal and testosterone. You would measure these hormones only under specific conditions. Each hormone has its own normal range, but this should only be measured if the woman has features of hyperandrogenism, like hirsutism, which is especially if it is severe and rapidly progressing, or there are other features like clitoral hypertrophy, hoarseness of voice, or male pattern of baldness. Or when you are suspecting the androgen excess tumors, that is adrenal tumors or late onset congenital adrenal hyperplasia. So to summarize, I would take you back to where I began. Our aim is to very rapidly segregate the couples into these three categories: potentially correctable, irreversible, amenable only to ART, or irreversible, which requires only adoption and donor insemination. And remember, the patient has come to you to achieve a pregnancy in the shortest possible time, in the most cost effective way, and in the safest way possible. Thank you very much. Should we take questions at the end of both the talks? I think that would make more sense. So let me proceed with the second talk that I will be giving.
Right.
And that is on ovulation induction. Are you able to see this slide?
No, sir.
Okay, let me go to that again. Okay. So we then move on to the second talk, and that is ovulation induction in an anovulatory woman and a stepwise approach to treating anovulation. Now, anovulation means failure to release an oocyte from a mature Graafian follicle during a menstrual cycle. Sometimes anovulation is physiological, and this is at the extremes of the reproductive life of a woman, around the time of menarche, when the hypothalamo-pituitary ovarian axis is still immature, or around perimenopause, where it is more likely to be of ovarian origin because the ovarian reserve has depleted. But when you have anovulation between these two extremes, then it is causing problems. So let us see the basic fundamentals before we move into the management. How does normal ovulation occur? It begins with the pulsatile release of GnRH from the hypothalamus. This acts on its receptors in the pituitary. The pituitary responds by releasing FSH and LH. This has to act on the follicles, the granulosa cells within the ovaries. The follicles start to grow and they start to secrete estrogens to begin with. This estrogen gives a negative feedback initially to restrict the number of follicles. And when the follicle has grown, it gives a positive feedback for the pre-ovulatory LH surge. This leads to the release of LH, which leads to ovulation and the subsequent secretion of progesterone. So you need an intact, functioning hypothalamo-pituitary ovarian axis with its positive and negative feedbacks. Any problem in this axis, any disturbance in this axis will lead to anovulation. This will have various clinical manifestations, but the commonest ones would be oligomenorrhea, that is infrequent menstruation, abnormal bleedings, or complete amenorrhea. And all of this would eventually lead to not only infertility, but certain other issues like uninterrupted proliferation of the endometrium, leading to endometrial hyperplasia and sometimes endometrial carcinoma. So treating anovulation or treating the negative effects of anovulation is not only relevant for infertility, but also for preventing endometrial pathologies. Now let us see how common this is. It is very difficult to estimate the incidence of anovulation because only you can look for it only in a patient who comes to you. So it is traditionally under-detected and under-reported, but there is estimated that it happens in about 6 to 15% of couples. If you look at all patients who come for infertility, this accounts for nearly 1/5 of females who come for infertility treatment. So a large chunk of patients. The first thing when you see a patient having anovulation is to classify the patient into one of these three categories. And let me take you through them once again. Baseline FSH, estradiol levels. Low FSH, low estrogen, which means neither is the pituitary functioning nor is the ovary functioning. The cause is at the level of hypothalamus. WHO1, hypogonadotrophic hypogonadism. Normal FSH, normal estrogen. Pituitary is functioning, ovary is functioning, but the problem is with the feedback or the pulsatile secretion, very common polycystic ovarian syndrome. High FSH, pituitary is working overtime, but the ovaries, estrogen is low, the ovaries are not functioning. There is an ovarian problem, premature ovarian failure, hypergonadotrophic hypogonadism. So the first thing that you do is measure these hormones and you decide which category does the patient fall into, because the treatment for all these three is completely different. So based on this, whether it is hypogonadotrophic hypogonadism, hypothalamic amenorrhea, or hypopituitarism, or a PCOS, you will have different findings and you decide on the line of treatment. So let us start with the basic principles. The basic principle of ovulation induction is to find the cause and hence treat the cause. So you cannot have one fixed approach for all types of anovulation. The second is to sit with the patient and discuss the problem, because pregnancy may not occur, or for that matter, even ovulation may not occur in the first treatment cycle. So they need to be aware and they need to be patient that this might take time. Let us then start with the first category of patient, and that is of hypothalamic origin. Commonly seen because of hypothalamic or pituitary tumors, or it's sometimes also seen in extreme obesity or eating disorders like bulimia, or because of pituitary tumors or hyperprolactinemic tumors. So if you have a pituitary or a hypothalamic tumor, you start by treating the primary cause. If you find certain disorders like Kalman syndrome, Sheehan syndrome, or syndrome secondary to cerebral irradiation or tumors, again, you need to look for these possible causes. And if required, you do a MRI or a CT scan to find out if there is any primary cause. We should also put measures to improve the general health before embarking on fertility treatment. But the ultimate treatment for treating this type of disorder is essential replacement therapy. These are patients who lack in pituitary FSH and LH, and you have to treat them by replacing this. It is like treating hypothyroidism by giving thyroid supplements. Here, standard ovulation induction will consist of giving injectable gonadotrophins only, along with regular monitoring, along with administration of HCG for inducing the pituitary, the final LH surge. Because these women do not have a functioning hypothalamo-pituitary axis. Here, HMG is the recommended treatment because they are deficient in FSH and LH both. Clomiphene citrate will not work. Aromatase inhibitors will not work because the hypothalamo-pituitary axis is not functioning. They need hormones, they need gonadotrophins, and they need both FSH and LH. We generally start with a dose of 75 units per day for patients in whom the threshold is not known. You give this dose for a period of at least 1 week, monitor the response, and then you increase in increments of only 33% if and when required. Monitoring by and large is done by ultrasound because you can look at the endometrial proliferation and growth of the follicle, which is a target hormone marker for estradiol administration. The number of days required to induce this would vary between 10 to 20 days. It is sometimes believed that in these women who have chronic estrogen deficiency, it is worthwhile to give them cyclical estrogen progesterones for a few cycles before you start the ovulation induction to improve the endometrial response. And their uteruses are also very small. So you give them a cyclical estrogen progesterone withdrawal for a few cycles, and then you start inducing with gonadotrophins, FSH and LH both, that is HMG. What about class 3, hypergonadotrophic hypogonadism? These are patients who have completely non-functioning ovaries, absent ovaries, streak ovaries, Turner syndrome, no antral follicles. These are the patients in whom there is no chance of ovulation. This could be primary or it could be secondary. Secondary is sometimes because of either radiation or chemotherapy, surgical removal of tumors or of ovaries, or sometimes even iatrogenic due to overzealous and excessive ovarian drilling, or when large ovarian cysts are removed, which leaves behind significant ovarian damage. So this is a category where no treatment is possible. The only option is oocyte donation. This leaves us to the second category and the largest chunk of patient. The commonest problem in this category is the polycystic ovarian syndrome. This was discovered in 1935 by Dr. Stein and Leventhal, who presented a series of 7 patients who had hirsutism, amenorrhea, and enlarged ovary. Because their ovaries were enlarged and he found them accidentally during laparotomy, they thought of doing a wedge resection and removing the ovaries. And to their surprise, they found that these women started with regular menstruation and conceived, and this led to the whole treatment of wedge resection and ultimately ovarian drilling. But this condition is far more complex than what it was earlier thought, because there are multiple pathways working into this. One, there is altered gonadotrophin secretion, there is insulin resistance, there is chronic hyperandrogenism. So 3 things working together: altered pulses, insulin resistance, and chronic hyperandrogenism. All this contribute to inhibition of follicular development, follicular atresia, and you have a large number of atretic follicles in the ovary which keep on secreting low doses of estrogen, leading to unopposed hyperestrogenemia. There have been numerous definitions which have evolved over a period of years. The commonest ones that are being used today are either the ASHRAE ASRM Rotterdam criteria, which means that you need 2 out of the 3 criteria. One is the polycystic ovarian morphology. Second is clinical or biochemical evidence of hyperandrogenism. And third is clinical or biochemical evidence of ovulatory dysfunction. We also have the latest 212 National Institute of Health criteria, which is an extension of this, where you need 2 out of the 3 criteria. And they've also classified 4 specific phenotypes of the PCOS. If they have all the features, it is phenotype A. If it is hyperandrogenism with ovulatory dysfunction, it is phenotype 2. Hyperandrogenism with polycystic morphology, it is C. And if it is only ovulatory dysfunction with polycystic morphology, it is phenotype 4. So we have 4 separate phenotypes of the polycystic ovarian syndrome based on whether 2 and which 2 of the 3 criteria those are present. One challenging complicator in PCOS is obesity, because adipose tissues have an aromatase activity which converts androgens to estrogen, which also leads to persistent elevated estrogen. There is a decrease in sex hormone binding globulin, which leads to increase in again peripheral estrogen. And this also contributes to insulin resistance and ultimately hinders follicular development. So obesity is a big contributor to the anovulation, but all women with PCOS are not obese. So now how do we go about treating anovulation in a woman with PCOS? You need to have a stepwise approach: lifestyle modifications, ovulation induction, surgical management with ovarian drilling, or the use of assisted reproductive technology. So the first step in this is PCOS is lifestyle modification, especially if the woman is obese and has a high BMI. It has been shown that nearly 50% of these women are obese, and if they follow a proper exercise and a diet plan, leading to even a 5% reduction in weight, mainly the central abdominal fat, this will lead to significant metabolic improvement and improvement in the reproductive functions. So any diet which reduces the glycemic load is beneficial. And we know that if you reduce the energy supplement by 30%, that is, if you reduce the caloric intake by 500 kilocalories per day, it will help us achieve a 5 to 10% weight loss. There is limited evidence as to which specific diet is better than the other. All are equally good. Most important is it should be something which is sustainable. So what does the guidelines tell us? That this weight reduction measures should be introduced before you start any of the ovulation induction drugs. So let us then move on to the drugs that are available. Now the first and the oldest and still probably the most commonly used is clomiphene cyclate. It is a selective estrogen receptor modulator. It blocks the estrogen receptors and leads to an secretion of FSH and LH from the pituitary. So it induces follicular growth, not ovulation. Ovulation will eventually occur by the LH surge in response to the positive ovulation, to the estrogen positive feedback. This was the first choice for many, many years. It is now, along with aromatase inhibitors, both have become the first choice. It is extremely cheap, orally administered, very few side effects, and has a very long proven safety profile. So how do we give this? Use certain basic principles. You start at the lowest dose of 50 milligram. You increase it month on month if anovulation persists. If you achieve ovulation, then you do not increase. And if you do not achieve ovulation, you should increase. Most ovulation occur with a dose of 150 milligram for a period of 5 days. The problem is anti-estrogenic actions. So sometimes it leads to a decrease in secretion of cervical mucus, or it leads to thinning of the endometrium. Now, when do you start this clomiphene citrate? Which day of the cycle? Now, traditionally, in the early days, a woman was called to the doctor's clinic after her bleeding stopped somewhere around the 5th day of the period, and hence clomiphene was started from the 5th day. But we now know that in an anovulatory woman, any 5 days of the cycle is okay. You could start it from day 2, 3, 4, 5. It is immaterial. But the earlier that you start, higher is the recruitment potential. This is what we know from studies, that that first ovulation, if you give on giving clomiphene, nearly 75% of the patients will achieve ovulation, and nearly 38% of the patients, that is half of this, will achieve pregnancy in the first year. Majority of the pregnancies will occur in the first 6 ovulatory cycles. So approximately 75% of these women will ovulate, and it occurs that the conception rate per cycle is somewhere around 22%. Let us go back to my first slide, first talk, fecundability in a woman, 20% in the first month after marriage. And this is essentially what we are achieving with clomiphene citrate. The duration, lot of studies have shown that most pregnancies occur in these first 6 ovulatory cycles, and hence clomiphene should not be given for more than 6 ovulatory cycles. But you may exceed up to 12 in exceptional cases on individual basis. However, it is better to move to the second line of therapy if 6 ovulatory cycles have not succeeded. So you give 50 milligram. If she ovulates, you continue. If there is no ovulation, you step up to 100. If she ovulates, you continue. If she does not ovulate, you step up. And if she ovulates, if she does not ovulate, you go to gonadotrophins. If she ovulates, but if the endometrium is thin, you go to gonadotrophins. If she ovulates, but there is no pregnancy, you move to gonadotrophins. So the key points, clomiphene still remains the drug of first or second choice for inducing ovulation. You decide on the dose based on the woman's BMI and age. The starting dose is 50, maximum dose is 150. We then move on to the second category of drugs, and those are the aromatase inhibitors. The commonest one is letrozole, and this acts by blocking the conversion of androstenedione to estrogen. It is given in a dose of 2.5 to 5 milligram. It has now been approved by the Drug Controller of India, but you need to check in your own country whether it has been approved for use for ovulation induction. The advantage of this is that since it does not block the estrogen receptors, there is no detrimental effect on the endometrium or cervical mucus. And because the negative feedback is not turned off, there is a lower risk of multifollicular development. But there are some gray areas, as I had mentioned, is about its off-label use and long-term safety, because it has been used for a shorter period of time compared to clomiphene. But studies have shown that the results with this are comparable with clomiphene citrate. So what does the ESHRE consensus tell? That women with PCOS are more likely to both ovulate and have a live birth with letrozole compared to clomiphene as the first line of treatment. And the likelihood of live birth increases with letrozole predominantly because of the absence of the anti-estrogenic actions. Now, when these two have not succeeded, we then move on to the use of gonadotrophins. Before you start the use of gonadotrophins, you must counsel the patient because the treatment is expensive. And secondly, an occasional patient may over-respond, where you might have to either cancel the cycle so that the cost of treatment is wasted, or you could convert it into an IVF cycle where the cost of treatment is increased. So this should form a part of pre-treatment counseling. Second, before you start inducing, try to understand how this works and certain very basic physiological principles. The first is what is the threshold. Now, the threshold is the lowest dose of gonadotrophin at which an amenorrheic and anovulatory woman would respond by producing a single follicle. That means this woman needs X international units of gonadotrophin, which is the threshold to produce one egg. These thresholds could be very small in the range, could fluctuate in the ranges of 10 or 30%. So the idea is to give the gonadotrophins just above the threshold and maintain it above the threshold for a very short period of time, which is called the window, so that you have only one follicle. Because if you give it for a longer period of time, you will recruit a larger number of cohorts. Or if you stimulate above the threshold, see what would happen. So if you go above the threshold by even half an ampule, you will stimulate all the entire cohort available on that day. It is not that if the patient's threshold is 50 international units, that if you give her 50, she will produce one follicle. If you give her 100, she will produce two follicles. If you give her 150, she will produce three follicles. No. The moment you exceed the threshold by 37.5 units, you will have the entire cohort is getting stimulated. And this in a woman of PCOS is 12. So from no response, you will suddenly see 10 to 12 follicles if you exceed the threshold very rapidly. So how do you give the gonadotrophins? If you look at the physiology, the pituitary releases higher FSH for the first few days. Once follicular recruitment happens, the ovaries secrete estrogen, and this tells the pituitary to lower the gonadotrophins. So in the step down protocol, we try to mimic this. You give the higher dose for the first few days, and you then keep on reducing the dose. The challenge here is you do not have a dynamic estradiol feedback mechanism which the pituitary has. So if you reduce too early, no follicle will develop. If you are late in reducing, larger number of follicle develop. So even though this looks physiological, this is not used in practice. In practice, what you do is exactly the reverse. You start at a lower dose, you give it for a 4 or 5 day period, you monitor the response. If the response is good, you continue. If the response is not good, you step up. And this is the standard step up protocol where you give 75 international units for 5 days and you increase the dose by another 75 for another 5 days if there is no response. But this has a problem that if the threshold is somewhere here and you increase by an ampule, you will suddenly see a lot of follicles going up. So this conventional step-up dose is not recommended. And what is recommended is the chronic low-dose step-up protocol, where you start at a lower dose of half an ampule or at the most 50 international units. You give it for 7 days and you increase the dose again only by half an ampule and not by full ampule. So you give a lower dose and you step up very slowly. And this increases the chances of having a monofollicular ovulation. An adequate response is between 1, 2, or at the most 3 follicles with rising estradiol levels. Be careful when you step up the dose. If you are increasing the dose by a higher margin, the response can be sudden if you have crossed the threshold. So gonadotrophin therapy for ovulation induction, studies have shown that whether you use recombinant FSH, urinary FSH, highly purified FSH, or highly purified or simple HMG, there is no difference in the live birth rates. So which gonadotrophin you use does not matter. So whether it is recombinant or it is urinary, the results are by and large the same. So to summarize, you start at a lower dose, you continue this for long periods of time before stepping up, you make smaller increments, the chances of having monofollicular ovulation is much higher. This also requires intense monitoring. And we should have strict cycle cancellation criteria because the risk of ovarian hyperstimulation and multiple pregnancies is high with these gonadotropins. What about the use of various adjuvants? Insulin sensitizers, metformin, or the glitazones. Studies have shown that metformin is not recommended, and this is the practice committee guideline, that for induction of ovulation, it should not be used as the first line because clomiphene and letrozole are more effective than metformin alone. So metformin alone does not help in improving ovulation induction. At best, it can be used as an adjunct to clomiphene. The newer drugs on the block are the myoinositols and the dechiromyoinositol. These are all isomers of the C6 sugar family, and they act as an intracellular second messenger, especially for insulin. Though there have been many studies till date showing some positive effect, the ASHRAE guideline still puts this as an experimental therapy and encourages that we need more trials before these are being put in routine clinical practice. This then brings us to the use of surgical management of polycystic ovarian syndrome. Now, the procedure that is being described here is laparoscopic ovarian drilling. What is being done is using some electrosurgical source, numerous holes are drilled. It was traditionally used for patients who were anovulatory with clomiphene citrate and could not afford gonadotropin therapy. The rationale behind this was that it destroys the ovarian stroma, which is the source of androgens. So by destroying this ovarian stroma, you lower the androgen levels. You achieve the effect what was achieved by Stein and Leventhal by doing a wedge resection. And this will lead to sustained endocrinal changes, which will help in regularizing menstrual cycle and inducing ovulation. It is typically reserved for patients who have very high LH with a normal BMI, thin lean BMIs, shorter duration of infertility, but it is never indicated for non-fertility indications like managing menstrual irregularities or hyperandrogenism. The only indication is if the woman has infertility, never for non-infertility indications. You can use either electrocautery or laser. You make between 4 to 10 punctures depending on the size of the ovary. It should never be used repeatedly. If it has been done once, it should never be done again. And it is important to note that it is an invasive surgical intervention carrying a small but a definite risk of not only reduced ovarian reserve, but complete loss of ovarian function and also the risk of adhesion formation. So it should be very, very judiciously used if at all. So it is the second line of treatment when the oral medications have failed, and the patient should be explained the various risks of this procedure. And this then brings us to the last resort when weight reduction, anti-estrogen therapy or surgical therapy or ovulation induction in any form has not succeeded. We then move on to IVF. It is also recommended when there is an associated reason for infertility, tubal factor, the need for PGT, or a concomitant male factor. You should also remember that using IVF with single embryo transfer, we are also eliminating the risk of multiple pregnancies. But there are certain issues in ART also because the ovaries are more sensitive to the gonadotropins. So you use the GnRH antagonist protocol, never the agonist. You use an agonist trigger and do a freeze-all approach if the woman is at risk of hyperstimulation. But in spite of all this, it is still probably the most effective way to achieve pregnancy in a woman with resistant PCOS. So with this, I would like to summarize that before beginning treatment, you should exclude all health issues. You then use a stepwise approach. You do proper pre-treatment counseling, begin with lifestyle, weight reduction, then move on to the oral drugs like clomiphene, letrozole, restrict metformin to those with glucose intolerance, If this does not succeed, the second line is either gonadotrophins or ovarian drilling. With the problems of gonadotrophins are intense monitoring and multiple pregnancy, and of surgery or permanent reduction in ovarian function. And when all these fail, you can then move on to IVF, which is still probably the most effective treatment, especially in elderly women. So you should have a patient-tailored approach for ovarian drilling based on your initial screening and counseling. Thank you very much for giving me this opportunity, and maybe we can have questions or whatever you say. Thank you very much.
Thank you, sir, for giving very insightful and with clear messages. It was I hope it is very beneficial to our viewers, and they have also made comments that, sir, you have made it very simple and covered all the things. And there are some questions that we'll be taking. Sir, they are asking significance of LH levels on day 2 and decision for what gonadotropin to give.
So this was popular once upon a time when people used to measure the LH levels and then decide whether to give FSH, recombinant FSH or HMG. Now studies have shown that second delay day 2 LH levels do not have any value and you need not measure them. In terms of gonadotropin usage also, all studies have shown that results are the same whether you use urinary or recombinant FSH or HMG. So this practice of measuring LH on day 2 is no longer recommended.
Thank you, sir. And what hormones to check and when during IVF means they are asking what hormones to check during IVF stimulation.
I think we will discuss this when we have full sessions on IVF,
right,
because this will be a long answer.
Right, sir. The other question is, as in your first presentation, sonosalpingography, HSG, and laparohysteroscopy. Out of these three, one should go for which? Means either SS. What do you recommend?
So this is a $1 million question, and you will not have one answer which will fit every patient. So the decision needs to be based on the patient. I will give you two extreme examples. You have a very young woman who is clinically and on examination completely normal, and you are planning a donor insemination. It is very unlikely that she will have a tubal factor, and a simple sonosalpingography or HSG will suffice. On the other side, you have a woman who is 34, 35, married 10 years. On examination, you find pelvic tenderness and you're suspecting a pelvic pathology. You should straight away go to a laparohysteroscopy. So it depends on your clinical findings, age of the patient, duration of infertility, and your treatment plan. Laparoscopy, hysteroscopy is the most conclusive and the most complete test because it gives you option to treat the patient. HSG or a sonosalpingography are the simplest ones, but they give lesser information. So these are ideally complementary tests, and based on the patient profile, you choose which test to offer to which patient.
Right, sir. Other question is similar for the ovarian reserve test. Out of AMH and AFC, should we do both or we prefer AMH?
So as a routine, antral follicle count is sufficient because it is something which you will be doing yourself when you scan the patient. You are able to visualize the ovary, you are able to visualize the antral follicles. So if that is normal, you may not carry an AMH for every patient. One would measure an AMH if your response to ovulation induction does not correlate well with your antral follicle count, or when the patient has a low number of antral follicle count and you want to again collaborate your finding with the AMH. So as a rule, a well done antral follicle count is sufficient. AMH is an additional test which can help you.
And sir, as you told us that in endometriosis patient there can be false AMH. So if we suspect endometriosis, we should go for AFC mainly.
So see, endometriosis, especially chocolate cyst, even antral follicles is sometimes a problem because the ovary is filled with the cyst and you cannot measure. The only important message from this is that in presence of large endometriomas, if the AMH is elevated or is normal, don't get carried away believing that the ovarian reserve is good. Take that AMH with a pinch of salt.
Correct, sir. And sir, there are many questions, but I will be taking 2 or 3. What's your opinion about the patient with unilateral unhealthy tube with hydrosalpinges with low ovarian reserve AMH 1.5? Is laparoscopy should do before IVF?
So in a patient who has a low ovarian reserve and has a hydrosalpinx which is visible on ultrasound and large, I would remove the fallopian tubes. You also have an option of doing an IVF, creating the embryos and freezing the embryos before you do this surgery, because sometimes the surgery, the electrocautery used during the surgery can also damage the ovarian reserve. So maybe a better option is to do IVF, remove the eggs. The hydrosalpinx will not interfere in ovarian response. It only interferes in implantation. Then proceed with removal of the hydrosalpinx.
Sir, this other question is for PCOS, for biochemical and hyperandrogenism, do we need to do all androgens, means testosterone, DHEAs, and free testosterone?
No. So again, as I said, to diagnose polycystic ovarian syndrome, you need 2 out of the 3 features. Amongst the 2, one is hyperandrogenism. This also could be clinical or biochemical. So if the patient has clinical features of hyperandrogenism, you don't need to measure the androgens. If the patient has clinical features of hyperandrogenism with a polycystic ovary, you don't need to measure the hormones. If the patient has polycystic ovarian morphology and has irregular cycles and ovulation, you don't need androgens. So the need for androgens, first of all, is extremely limited. You don't need to measure. If you want to measure, you should only measure the ovarian androgens, that is androstenedione. But by and large, for 99% of the patients, you don't need to measure androgens. On your clinical examination and your ultrasound, you will be able to come to a decision.
Right, sir. And there are many questions, but one last question I will be asking, sir. Following ovulation induction means how many cycles means you suggest to shift to IVF, or in between will be considering IUI?
So the paradigm for treating a patient with unexplained infertility, the algorithm is that you do 3 cycles of ovulation induction. If the patient is young, you can go up to 6 cycles of ovulation induction. If the patient is older, you do 3 cycles of ovulation induction. Then you proceed with between 1 to 3 cycles of IUI, again depending on the age of the patient. Young patient up to 3 IUIs, older patient maybe only 1 IUI, and you then move to IVF. So young, good prognosis patient, up to 6 cycles ovulation induction, up to 3 cycles IUI, and then IVF. Older patient, poorer ovarian reserve, maximum 3 ovulation inductions, maximum 1 or 2 IUI, and then IVF.
Thank you, sir, for your very elaborate reply. And other question is means for cycle cancellation, you suggested strict cycle. This will be the last question. Strict cycle cancellation. So, how many follicles do we consider? 2 follicles?
So the maximum number of follicles that one should aim for in simple ovulation induction is 3. So 3 follicles above 14 millimeters, you should either cancel or you can convert it into an IVF cycle.
So if there are 3, it should be converted into IVF or cancelled.
Yes.
Right, sir. So with this, I think we conclude because the time is the constraint. Otherwise, there are many questions and they have appreciated a lot. And they are simply saying that it was wonderful. Thank you, sir. On behalf of INTAS, we are very thankful to you. I think Dr. Padia would like to say something.
Yes, doctor, thank you so much for your very nice and informative lecture based on evidence-based and up-to-date information. Thank you so much again, and hope we will meet soon again. Thank you.
Thank you very much. Thank you for having me. Thank you very much.
Thank you so much.
Thank you, Dr. Fadia.
Thank you so much, doctor.
So We conclude, ma'am. Support. So I think
Yes, ma'am.
yeah. So we can conclude now.